Hi everyone, thanks for coming today. My name is Samantha and I'm from Franklin Pierce University, and I'm here doing an internship with Dr. Tara Sullivan here at Honor Health. And today I'm going to be talking about the obturator internus muscle and how it affects patients in the orthopedic and pelvic floor physical therapy settings. Here are the objectives and the main points I want you to take away from this lecture. The first one is to identify the role and function of the pelvic floor muscles and recognize referral patterns of the obturator internus and how they present in the orthopedic patients. And recognize signs and symptoms of pelvic floor dysfunction, also known as PFD, and specifically related to the obturator internus. The next one is to determine when Kegels are indicated or contraindicated and how to prescribe them appropriately. So I'll talk about why Kegels would be hard to prescribe, especially in the orthopedic setting. And then the last objective here is to incorporate special tests and screening questions into orthopedic exams to determine the indication when it's indicated to refer to a pelvic floor physical therapist. This is just an overview of the pelvic floor functions, and we call these the 5 S's. And so if there's a dysfunction in any of these, or when the pelvic floor muscles are not working correctly, they could either be overactive or underactive, they could be weak or not coordinating properly with timing. And if there's a dysfunction in any of these S's, then that's when we see pelvic floor dysfunction, chronic pain in the pelvic floor, things like that. So the first S is sphincter control. The pelvic floor muscles open and close the openings such as the urethra and the anus, and for females, the vagina. And these allow for body fluids and waste to leave the body. So these muscles should be pretty much under voluntary control. And so if there's any leaking or incontinence, and that's not normal, just because we are in control of opening and closing these openings. The second S is sexual function. The pelvic floor muscles are also highly involved in sexual functions. They have a role in bringing and keeping blood flow to the sexual organs, as well as maintaining mobility and integrity of the tissues, and they allow for us to have intercourse and as well as orgasm. So dysfunction in this domain, we can see patients who have pain with sex or are unable to even have intercourse or orgasm. The next S stands for support. The pelvic floor muscles create support for our internal organs, especially the bladder and the rectum, as well as the reproductive organs. And this is why we see a lot of dysfunction in patients after surgeries, such as hysterectomies and after childbirth. There's a very close relationship with the bladder and the pelvic floor, so dysfunction in this support can lead to prolapse of the organs, including a cystocele or a rectocele. The next S is stability. So stability in the pelvis is also maintained by the pelvic floor, and the pelvis is a relatively static set of bones. So they take a lot of brunt of the impact that the body experiences, and the pelvis also allows for load transfer of movements from the upper extremity and lower extremity, and so it definitely needs to maintain stability, and the pelvic floor helps support that. So when the pelvic floor is not doing its job, we can see things like diastasis of the pubic symphysis. Patients can have coccyx pain as well. And the last S is sump pump. So this allows for lymph fluid to be drained and pass through the pelvis. And if there's any dysfunction in this system, it can lead to things like pelvic congestion, which can cause significant pain in patients. This is just a picture of an overview of the anatomy of the pelvic floor. I really like this picture just because it shows the complexity and the intricate layers of the pelvic floor. And you can see the nervous system and the fascia and the musculoskeletal system that are all involved in the pelvic floor. I'm not going to go into detail about each specific muscle of the pelvic floor, but they're generally just broken down into 3 layers. This is layer 1, which is a superficial muscle layer, and it's the same in males and females, and the functions are pretty much the same. And the main function is to support the perineum and open and close the urethra and vagina, and also they play a big role in sexual function by maintaining blood flow for erections and orgasms. Layer 2 is also called the deep perineal pouch or the fascial sandwich because this layer is surrounded by a layer of fascia on both sides, and this creates more stability of the pelvic floor along with the urinary system. This also pretty much has the same role in providing support as well as opening and closing the holes for the urethra and the vagina in females. And the only difference between the males and females is that females have 2 extra muscles that the males don't have, which also just pretty much just open and close the urethra and vagina. Here's layer 3, so this is the deepest layer of the pelvic floor muscles, so this is the most internal, and I'm going to talk a little bit more about this one because this is the most relevant to pelvic floor dysfunction, and you can see a lot more patients will have problems with this layer and the muscles within this layer. The pelvic diaphragm is made up of a group of muscles called the levator ani as well as the coccygeus. So you can see in this slide that the levator ani is made up of the muscles in yellow, and the coccygeus is in blue. And levator ani directly translates from Latin, meaning to lift the anus, and so this function of the levator ani is to support the bladder and rectum to maintain continence. All of these muscles are common pain generators in pelvic floor dysfunction. And then I'll talk a little bit more about the pelvic walls in the next slide, and which are made up of the piriformis and obturator internus, which are colored in green. And these are both really important muscles because you can see how closely related they are to the levator ani and other pelvic floor muscles, and they're the link to the rest of the body. This is just more information on the pelvic diaphragm. On the picture on the right, you can see how the pelvic floor muscles create more of a hammock that supports the internal organs. And the pelvic diaphragm is, again, made up of the layer 3 muscles as well as the pelvic walls, which include the obturator internus and the piriformis. One of the things is that the pelvic floor muscles are made up of 70% slow twitch fibers, which means they're pretty much active throughout the day, and they are muscles that are made for endurance. And so only 30% of the muscles are fast twitch fibers. So when we see patients that have overactive pelvic floor muscles, they're in a constant state of spasm, which would definitely cause dysfunction in these patients. And the obturator internus and piriformis are also part of the pelvic diaphragm. And in the picture below on the right here, you can see how the sciatic nerve is sandwiched between the posterior part of the piriformis and anterior part of the obturator internus. And this can actually create sciatica-like symptoms for patients. And so if you have a patient that comes in and says they have recurring sciatica that they've had for years on, and they've been treated for different things. They've been treated for their back, they've been treated for piriformis syndrome, but they still have sciatica and it's never gone away. This could be one of the things that you might want to look at in these cases. This is just more specific on the obturator internus, the origin, insertion, nerve innervation, and action. The action is going to be the most important here because the obturator internus is an external rotator of the extended hip, and it also abducts the flexed hip. So really the takeaway here is that the obturator internus is the only hip external rotator that doesn't turn into an internal rotator once the hip is flexed past 90 degrees like the piriformis does. So it's always an external rotator. There was an EMG study by Hodges et al. In 2014 that revealed that the obturator internus was the first muscle activated when performing hip abduction and external rotation, and the highest EMG activity of the obturator internus occurred when the hip was in extension, external rotation, and abduction. So this just indicates that the obturator internus has a really substantial role in being activated with different hip movements and not just external rotation and abduction. So it has a high potential to be overworked. This is a picture that highlights the ATLA, which is the arcuate tendon levator ani, which is a connective band of fascia that connects the obturator internus to the levator ani, as well as the pelvic walls, and it essentially connects the pelvic floor muscles with the surrounding structures, so it has a role in linking the entire fascial system of the pelvis, as well as the hips, abdomen, back, and it also assists in creating support for the bladder and other internal organs. Here's a concept of overactivity versus underactivity of muscles, which everyone's familiar with. With the pelvic floor, it's really challenging to assess whether the muscles are over or underactive without an internal exam. So I just wanted to talk about if you were to assess muscles on your patients in the orthopedic setting, you would want to be able to feel your patient's muscles. You want to feel palpate whether it's tight, shortened, atrophied, anything like that. And you don't want to just look at them, right? So same thing goes for pelvic floor. You want to be able to get a good feel by palpating what the muscles are doing. So when the muscles are overactive, they're typically in a shortened and spastic state and usually unable to voluntarily relax. And there's typically impaired coordination, usually due to some type of stressor, such as a trauma, could be surgery, direct fall in the pelvis, or also some type of sexual trauma or some history of sexual trauma. In these patients, we typically do not assign Kegels because we don't want to further create contracted muscles or muscle spasms in muscles that are already hypertonic. And then underactive muscles are typically weak and lengthened and unable to voluntarily contract. This could be due to pregnancy, childbirth, prolonged stretching, and other things such as straining, aging, and atrophy. And for these patients whose muscles are underactive, we usually actually prescribe Kegels for these patients, but we have to make sure that we assess them first. And then another point that I wanted to make is that tone does not equal strength. You can have someone who has really high tone, hypertonic muscles, but they can essentially be very weak. And this kind of goes along with a patient if one of your patients has hypertonic upper traps and it's contributing to their pain and dysfunction, you're not going to prescribe them shoulder shrugs or anything like that. And the takeaway here is that when we're examining and treating patients, it's based on the concept of whether the muscles are over or underactive that we decide to prescribe these exercises or not. These two studies right here pretty much summed up the fact that verbal cues can be ineffective for instructing patients to perform Kegels. Bump et al. Gave the instructions: contract the muscles you would use if you were trying to keep from losing your urine, or if you were trying to stop your stream after you started to urinate. And they gave these cues to all the patients and then performed the exam. 49% of them were actually able to perform some type of pelvic floor contraction without holding their breath. However, 25% of these subjects bulged instead of contracted, which is actually the opposite of what we want patients to do. And this type of activity actually promotes urinary leaking. And another study by Vermandel et al. In 2015 looked at postpartum women, 958 of them, and 33% of these women claimed that they knew how to do Kegels and that they were doing them, but once they were in the exam, they actually were ineffective at performing them. So the takeaway is that we actually don't want to cue patients to perform a Kegel, especially if we haven't done an exam, because we don't really know what's going on. So if you're telling your patients to squeeze, and if they're ineffective, they might actually be promoting urinary leaking behavior. This is a really good article here about pelvic floor muscle strengthening. This article was by Tuttle et al. In 2014, and it was published in the Journal of Women's Health Physical Therapy. They found that strengthening the gross hip musculature also strengthens the pelvic floor muscles. So they found that doing exercises such as clamshells, isometric hip external rotation, and monster walks, it improves the hip abductor strength, but it also improves pelvic floor muscle strength. So this tells us that if a patient has difficulty performing Kegels, this could be beneficial in helping to assist with pelvic floor muscle strengthening, even if you just do your typical ortho hip abduction exercises. However, I'm going to bring up this point that if the obturator internus is involved, patients might actually have increased pain performing these movements, such as clamshells and resisted external rotation. Here's just another slide about whether to Kegel or not to Kegel. So I talked about why Kegels are only prescribed after pelvic floor muscles are assessed, and only if the muscles are weak. And we don't prescribe Kegels if the pelvic floor muscles are overactive, as well as if there's any pain. And then I wanted to reinforce the fact that more is not better. And so we don't ever prescribe, never tell patients to do more than 30 to 80 repetitions per day. We don't say do them all the time. No, it's like an exercise that you're going to give your patients to do 1 to 3 times a day, and no more than 10 to 30 reps at a time. And so this is there is potential for overworking the muscles. There's also a direct relationship with activating the transverse abdominis due to overflow of the pelvic floor muscles. So it's possible to actually over-cue the transverse and overactivate the pelvic floor muscles. So in this case, you want to utilize breathing strategies such as diaphragmatic breathing to downregulate these overactive pelvic floor muscles. Here are some typical pain presentations of patients with pelvic floor dysfunction. Patients will report symptoms of groin and hip pain, as well as menstrual type cramping despite being on their period. You might get a patient that comes in for musculoskeletal issues. You'll probably be examining them for groin or hip pain, and you should be asking about bowel and bladder dysfunctions such as incomplete emptying, straining and pushing, as well as urinary frequency and leaking. And they might also have a history of endometriosis, as well as increased pain related to their menstrual cycle. This is just some more information on what you might see when you're doing your eval for your ortho patients. They might have poor sit, stand and sleep mechanics. They might have a sedentary lifestyle, and you might see some postural deviations such as lumbar lordosis, anterior pelvic tilt, as well as knee hyperextension. And then I wanted to highlight this point that all postpartum women, so all mothers who have just given birth, should have at least one pelvic floor physical therapy session after 6 weeks of giving birth. So this is really important just to make sure everything's healing correctly and everything's going as it should. This is just a study that surveyed 49 women with chronic pelvic pain, and they found that 80% of these women had urinary frequency, 65% of these women had pelvic or abdominal pain, and 92% of these patients had trigger points in the pelvic floor muscles in the levator ani layers. But also you have orthopedic presentations such as limited internal rotation. 29% of these patients had limited internal rotation as well. So this is just a pretty big list of things that you might find in a patient with chronic pelvic pain. And here are more musculoskeletal presentations. And again, like I said before, decreased hip internal rotation, as well as postural changes such as cervical spine lordosis, scapular winging, And these patients also might be in some type of chronic cycle of pain and postural dysfunction. And again, you don't really know what came first, the chicken or the egg. Are they in pain because of their poor posture, or are they displaying poor posture because of this chronic pain cycle? And then when you're doing your exam, you also want to think about asymmetries in their pelvis, such as the iliac crest, pubic symphysis, as well as doing some sacral testing, such as the P4, and as well as abdominal tenderness testing. These patients will also have more difficulty relaxing their pelvic floor and have a lower strength and endurance on these tests. Here's some more specifics about the obturator internus. You have referral patterns that can refer to pain in the buttock, ipsilateral thigh, the greater trochanter, and you might also have referred trigger points to the vagina and the perineum, as well as a feeling of fullness in the rectum. So these patients might complain about needing to go all the time. And then you might also have lower quadrant abdominal pain, such as appendix pain in the right lower quadrant. We've also had patients that have been to the ER because they think that their appendix is hurting, or think that they have an ovarian cyst that's burst or something like that. But really, the obturator internus shares the same fascia as the gastrointestinal system, as well as the appendix and the other organs in the lower abdomen, and that's why sometimes you have referred pain to that area. Here are a couple other orthopedic patterns that the obturator internus can have. There were a couple articles that talked about how the obturator internus mimicked sciatica pain, and in these cases there was a bacterial infection of the obturator internus that caused pain in the low back that radiated to the buttock and posterior thigh. And when these patients were treated with antibiotics and the infection went away, the sciatica symptoms also went away. You might also have patients with chronic hip pain that could be anterior or posterior, so you just have to pay attention to the location of pain and the type of the pain and the characteristics that your patient is talking about when you're doing your exam. And here are some special tests that you might do for your patients anyway with hip pathologies, but you might get some positive testing with the FADIR, which puts the obturator internus into a stretched position when the hip is in flexion, adduction, and internal rotation. And the forced favor test will put the obturator internus in a shortened position, but if you're having the patient resist that motion, you're going to actively contract the obturator, and if it's affected, then they're going to have some pain with that. And again, I talked about pain with clamshell or hip abduction, and if you're doing a manual muscle test for glute med or something like that, and the patient complains, and that's the only movement that actually recreates your patient's pain, you might be thinking glute med, but you might also be thinking obturator internus. And then other SIJ testing, such as the P4 and the Gillet's test, might be positive, as well as the Trendelenburg. So the piriformis stretch and the obturator internus. So why do pelvic floor therapists always say that we don't like the piriformis stretch, and why is it contraindicated with obturator internus dysfunction? So you might have your patient that's complaining about pain in the piriformis region. They'll point to that area of their hip and say they're constantly stretching it, but it's not getting better, regardless of how much stretching and lacrosse ball massage they're doing. But the piriformis stretch also actually puts the obturator internus in a shortened position, because I mentioned before that the obturator internus is an external rotator throughout the entire range of motion. So in this figure 4 position, the obturator internus is actually shortened and doesn't get stretched. So it will actually cause more pain in these patients. And there was also a study that revealed that the obturator internus, the greatest length change, was at 45 degrees of internal rotation and neutral flexion and extension. So this just says that the best position to stretch the obturator internus would be with the hip extended in a neutral extension position and internal rotation of 45 degrees. So what should your physical therapy examination consist of? You should definitely do a thorough musculoskeletal eval that includes a lumbar, pelvic, and hip screen to rule in or out involvement of any of these factors, as well as strength and endurance and looking for symmetry. The subjective history is probably the most important tool that you'll use when screening for pelvic floor involvement. You want to ask about mechanism of injury, whether it's a trauma, and if they have a history of surgery such as an appendectomy or hysterectomy or anything like that. Typically in patients with chronic pelvic pain, there's no direct MOI, and they'll say that it started all of a sudden, and they don't really relate it to anything specific. There's also a huge psychological component in chronic pelvic pain. So in these patients, you want to ask about depression and anxiety. They might display some fear avoidance behaviors, and it's important to ask about sexual dysfunction as well as bowel and bladder dysfunction, because a lot of these patients actually have pain with sex or unable to have sex, or they have some type of bowel and bladder dysfunction such as constipation or urinary frequency, urgency, or incontinence. So some questions to ask to screen for pelvic floor related dysfunctions. The goal is actually to determine the pain patterns and pain generators. So you want to know if the pain is local or referred, and what are the characteristics of the pain. Is it chronic, acute, or is the pain related to some type of joint issue, bone, ligamentous? Is it myofascial restrictions? Is there a neurological component? Is there a psychological component? And is it related to posture? And again, you want to ask about changes in bowel and bladder function, which you already are probably doing with the intake form, but then again, just bring it up with your patient when you're talking to them. And you might not bring these things up in the first session, but maybe a couple sessions down the line when you develop rapport with your patients and you get a better understanding of what's going on and if they're not, responding to your treatments as you're expecting them. And then again, thinking about the psychological component, whether there's anxiety or depression that's involved, and if they're displaying fear avoidance behaviors. So when to refer to pelvic floor PT, and we talk about how if your patient's progressing with orthopedic therapy, the typical interventions that you would be doing for hip or back pain, and if they're not responding, you'd want to reassess them within about 4 to 6 visits or 4 to 6 weeks. And if the pain patterns are not typically what you would see in a patient with, say, sciatica or a labral tear or anything like that. So you want to constantly be assessing and reassessing your patients and seeing if they're getting better or worse or if they're staying the same. And then we often forget that pelvic floor dysfunction can happen in anyone. So males can also have pelvic floor dysfunction, not just females, because everybody has a pelvic floor. Here are some clinical pearls that I just want you to take away from this lecture. So patients that have obturator internus pain can have increased pain with clamshell or resisted abduction exercises. So if your patients are complaining with increased pain with some of these hip strengthening exercises that you're doing, you might want to take a second look at that. And the piriformis stretch is contraindicated for patients with obturator internus pain. Every mother postpartum should have at least one pelvic floor physical therapy session 6 weeks after giving birth, as well as tone does not equal strength. So overactive pelvic floor muscles can be weak and they may be compensating for some type of instability. The obturator internus fascia is also connected with the fascia of the appendix and the GI system. So it could cause referred pain to the hips, glutes, abdomen, as well as the back. And if your patient has a history of endometriosis or any type of pelvic abdominal surgery such as a hysterectomy or appendectomy, they're at a greater risk for pelvic floor dysfunction. And hip strengthening exercises can also help strengthen the pelvic floor muscles. So Kegels are not always indicated to be cued, especially if you haven't performed an internal exam. And more is not better. So again, you don't want your patients to do more than they need to do because there's a chance for overactivity, and to refer to a pelvic floor specialist if your patient is not responding and progressing as expected with your orthopedic interventions. This is just some resources that Herman and Wallace has, which is a very well-known company that does a lot of research for pelvic floor therapy. And there's also a Find a Practitioner tool where you can locate or you can search for pelvic floor therapists by location. So if you have a patient in a specific location and you don't know anyone there, you can use this search tool. Thanks for listening. And if you have, you can go ahead and email me or message me. Thank you.